Thank you for joining Cancer Support Community Atlanta for What You Should Know About Cardio-Oncology, facilitated by Dr. Medepalli with Northside Hospital Cardiovascular Institute and moderated by Dr. Jones with Georgia Cancer Specialists. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, What You Should Know About Cardio-Oncology. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include virtual support groups led by licensed mental health professionals, nutrition seminars facilitated by an oncology dietitian with Northside Hospital Cancer Institute, stress reduction classes like yoga and Tai Chi, and of course education programs like these. And if you ever miss a live event, we encourage you to visit the video tab of our website where you can see recordings of past events. So for a complete schedule of events or to register for any of our programs, please visit our website. Again, that's cscatlanta.org. As a reminder, everyone will remain on mute for the duration of today's program. We invite you to enter questions into the program chat box, which Dr. Jones and Dr. Medepalli will address at the end of the program, time permitting. I'm excited to welcome back Dr. Jones to this virtual platform. Dr. Cheryl Jones is board certified in internal medicine and medical oncology. She completed her residency and fellowship at the Medical College of Virginia in Richmond, Virginia. Dr. Jones currently serves as the Vice President for Georgia Cancer Specialists, where she practices at the Macon location. Dr. Jones is active in local and state medical organizations and has served as the President of Bibb County Medical Society, the Chief of Staff for Coliseum Medical Center, the American College of Surgeons Cancer Liaison Physician, as well as serving on the Board of Directors for Medical Association of Georgia, the Middle Georgia Education Foundation, the Georgia Physicians for Accountable Care, the Middle Georgia affiliate of the Susan G. Komen Foundation, the American Cancer Society in Daugherty and Bibb counties, and the state of Georgia. So welcome, Dr. Jones, and I'm going to go ahead and pass it off to you to get us started.
Well, thank you, Katie. It's my privilege to get to introduce Dr. Medepalli. She's bringing with us over 20 years of experience in non-invasive cardiology, and her special area of interest has included women's cardiac issues as well as cardio-oncology. Her passion for cardio-oncology has led her now to be the chair of the Cardio-Oncology Task Force at the Northside Hospital Cancer Institute. She's also authored several publications, including one published just in January of 2022 on this exciting topic in cardiovascular research and cardiovascular medicine. So we're excited to hear what she's going to tell us today about this new and emerging field of cardio-oncology. Thank you, Dr. Medepalli.
Thank you, Dr. Jones. It's my privilege and honor to be with you and this, legend locally and oncology and provide this cardio-oncology services for our oncology patients for good cardiac outcomes along with their oncology good outcomes. So
I want to start by telling us what cardio-oncology is, Dr. Medepalli.
Sure. Heart disease and cancer are the top two leading causes of death in the United States, and both have similar cardiac risk factors. As many more drugs are being evolving, and the new oncological treatments out there every week and every day these days, new drugs are emerging. Those cancer drugs may have some potential side effects on cardiovascular system, and as the survival of our cancer patients is better and better every day, as they're living longer, the cardiovascular complications, we don't want our cancer-free patients with now with new cardiovascular complications. That is why this cardio-oncology is now rapidly emerging with the progress in oncology treatments. If we look at the graph, and I always am a big advocate of women in cardiology. Whenever I see any data in cardiovascular disease, I try to see what's going on between women and men, and if we look at the men and women top 2 leading causes of the death, both in men and women, the top 2 leading cause, A for cardiovascular disease in men and women, blue in men and red in women, and again, B is cancer. So the top 2 leading causes of death are cardiovascular disease and cancer. And we look at the age at which cardiovascular hits us, both in men and women again, men in blue, women in red. The average age, peak age is the rise from around 60 years onwards, the incidence and prevalence steeply increase. And if we look at what's going on with the cancer, and again, we look at all sites of cancer and the median age at diagnosis for women, mostly the breast cancer, and men prostate cancer, they're hitting again at the same time around 60s. So that's the 2 big causes of death in United States are coming at the same time. Both are coming, both the men and women have to deal with these problems at the same age kind of prevalence. The National Cancer Institute estimates at least 14 million cancers were alive in 2012, and this is increasing rapidly. By 2020, there were 18 million survivors, and by 2022, there will be 22 million survivors. And it's congratulations and great work from our cancer oncology colleagues. The survivorship is rapidly increasing. Our cancer survivors, it's a great news for us from oncology world. So if we look at the graph from 1970s compared to 2020s, this graph represents the survivorship in United States, and the people who are surviving, they're living longer and surviving the cancer. As we every year, it's steeply rising. And why is that? Because this is the number of research studies going on out there. For if we look at the hematology, oncology, immune system, respiratory, cardiology, cardiovascular. If we look at the new phase 1, phase 2, phase 3, new drugs coming out, new treatment options coming out, the blue represents oncology. The research is amazing. The number of drugs coming out from oncology research is steeply rising. That is reflecting back, reflecting in the survivorship. So if we look at the number of patients who are surviving, this is in 2019, we are in 2020, and if we project to 2030, still compared to, if you look at the prostate cancer, from 3 to 5, and here from breast cancer, the survivorship is significantly projected to increase steeply when we see what's going to happen in 2030. And we look at the graph, if we see the patients who are surviving non-cancer, if they have without cardiovascular disease, and cancer survivors with cardiovascular disease, at the end of 8 years, the survivors are much less if they have associated cardiovascular disease. So if we take care of this cardiovascular disease, cancer survivors will live longer and healthier. So that's where we are taking the heart to cancer. By taking care of this cardiovascular disease, we want our cancer survivors live longer and healthier. And if we look at the survivorship, the pediatric cancer, the children who survive their leukemias, lymphomas, if we look at when they reach 40 to 45 years old, they have 15-fold lifetime increased risk of heart failure compared with their matched controls. This study came out when they looked at the pediatric population, and what they did was they kind of studied the child who had leukemia or Hodgkin's lymphoma, and they compared with their sibling who didn't have. And when they compared to the siblings, the brothers and sisters, that the pediatric survivor had 15-fold increase of heart failure compared with match controls when they reached 40 to 45 years old. And if you look at older patients too, like breast cancer survivors, prostate cancer survivors, aggressive non-Hodgkin's lymphoma survivors, there are again 15 to 17% incidence of clinical heart failure after they survive in 5 years. And why is this happening? If in case this is the cardiovascular reserve, if we keep that in center, if the patients have pre-existing cardiovascular disease, heart failure, stents, previous CAD, history of valvular heart disease, or if they're diabetes, hypertension, the hyperlipidemia, and then women reaching their 50s and 60s, and they're getting menopause there, and abdominal obesity, insulin resistance, high blood pressure, depression, anxiety, immobility, weight, everything is coming at the same time. When the cancer diagnosis we saw, it's coming also around 50s to 60s. So if we take care of all these associated factors and keep the reserve up, then all the patient has to deal with is this risk, this insult of cancer coming in, and our oncology colleagues can give the chemotherapy, radiotherapy, and whatever it needs to get the cancer under control. So the heart has to deal with one problem rather than all these risk factors. So our goal is to protect the heart by giving cardioprotective therapy if they have risk factors of hypertension, high cholesterol, diabetes, and obesity is inflammatory and increasing. We heard from Katie before, encouraging exercise, depression, anxiety control measures, and and maybe soon we will be initiating survivorship program from cardio-oncology standpoint as well in our agenda to be done in the future soon. And if the patients are on like atenolol or hydralazine or some kind of usual blood pressure medicines, we try to kind of change to their oncology drug related cardioprotective therapy. So that way, when the oncology drugs come into the body and system, heart is protected with cardioprotective therapy, and they have less damage or reserve or heart dysfunction. So that's where that's why cardio-oncology plays a significant role as pre-chemotherapy and during chemotherapy and after chemotherapy to help that heart and maintain the reserve or improve the reserve to take the challenge of cancer and associated oncology treatments, which may include radiotherapy or chemotherapy.
Well, that's very, very exciting information. We're thrilled in the oncology world that we have an increase in cancer survivors.
Yes.
A lot of research, but then noticing that the cancer survivors are at an increased risk of cardiovascular disease. Now that's from their treatments as well, chemotherapy and radiation and medications, as well as their other lifestyle changes that can all be adjusted and adapted through these high-risk programs.
Yes, yeah. It's very exciting how the oncology is spearheading. Oh my God, it's very exciting. My mom is a cancer survivor as well with triple negative, and it's a blessing how you all are taking care of our cancer patients.
Well, it seems like we need to do a little bit more taking care of their heart while we're taking care of their cancer.
Well said.
So who should be considered to see a cardio-oncologist?
That's the great question. So what we want to see is who needs to be referred. I think the patients, we all are getting to that 50 to 60 or whenever the cancer diagnosis, we want to see ahead of time, before even the cancer therapy is initiated, because that way we can risk stratify the patients and adjust the medications, cardioprotective therapy. And we have special echo and strain imaging advanced technology to check the risk. And we have some biomarkers with immune checkpoint inhibitors. So we want to kind of start seeing the patient even before the cancer, pre-cancer diagnosis. So we want to see the patient when oncologists are planning their treatment options. And if any, the oncology treatment involves anthracyclines, specific groups of drugs like VEGF inhibitors, which have potential risk of hypertension, or immune checkpoint inhibitors like with immunotherapy or planned radiotherapy, and or patients are being considered for chemotherapy and surgery, and again chemotherapy and getting that surgery in between for pre-op clearances ahead of time. So ideally speaking, if high-risk cancer drugs, which are some of them are very well known, to be seen a week before even the cancer therapy, as soon as it's planned, and then optimize their cardiac health and cardiovascular risk factors and pharmacological therapy, and then continue support during the oncology with high-risk drugs if they are on, and some patients who are on received anthracyclines and radiotherapy into their survivorship.
So it seems like there are certain medications that may place patients at increased risk. I mean, certainly the ones that you've mentioned, the anthracyclines are commonly used in breast cancer, other women's health drugs with the VEGF inhibitors, often in the ovarian cancers, but also used quite a lot in GI cancers. There are also a lot of other medicines that can cause some other cardiovascular or even vascular and lipid changes as well. So, but if a patient is a survivor, that means that they have finished their treatment, can they also undergo cardio-oncology evaluation and potentially even reverse or improve their long-term outcomes?
Yeah, absolutely. Absolutely. Well summarized. Here, these are, in 1970s, the anthracyclines, they commonly called as red devil. We used to, but I don't know, in India, my mom received those and she said, I got some red devil. I said, oh my God, in 2009. So anthracyclines are very known for their cardiotoxicity. And there comes the tyrosine kinase inhibitors, called Herceptin, and all these drugs, trastuzumab, and later on, as you said, VEGF inhibitors like Sunatinib for urology cancers, GI cancers, and multiple myeloma-related cancers, immune checkpoint inhibitors. And recently, the immunotherapy, CAR T-cell therapy, have various incidents from 2 to 3%, less than 1%, to as high as 20 to 30%, 48%, depending on their associated risk factors. If patients have very less risk factors, diabetes, hypertension, high cholesterol, immobility, weight, and everything is taken care of, their risk is very, very low compared to patients who have associated high risk and already on prior valvular heart disease or prior heart dysfunction and compromised heart function. So usually certain groups of medications are known to cause certain more cardiac side effects, like anthracyclines can cause heart failure, myocarditis, and arrhythmias. The endocrine therapy, as you had mentioned, like prostate cancer or breast cancer survivors on estrogen modulators, receptor modulators, and prostate cancer with the androgen directed therapy. These have associated risk of metabolic syndrome. Triglycerides may go up, cholesterol may go up, insulin resistance may set in, and steeply the blood sugar may go up, cholesterol may go up, blood pressure may go up. That results in, this data supports that by 20% of prostate cancer patients who are on these androgen receptor antagonists, they can suffer a heart attack or heart failure or risks. If we don't, as soon as we start the therapy with cancer, we also start taking care of checking the cholesterol in 3 months and blood pressure periodically, and be aggressive in treatment of metabolic syndrome. And as you said, the radiation therapy patients, although these days with advanced technology, they're doing their best to limit exposure to the associated structures like heart and cardiovascular, neck radiation to the carotids, and abdominal radiation to the aorta. Because of heat injury, the inflammation, for example, left-sided breast cancer patients, I had certain patients who I followed, Dr. Bonta referred recently, with aortic regurgitation. The left side valve, aortic valve, is more commonly thickened and inflamed and doesn't close well and starts leaking. So we usually routinely screen patients after 5 years with a calcium score, heart scan, or some kind of ischemic evaluation. And we look for, like you had mentioned the other day, we were conversing about, you do routine screening for cancer and you find some calcification in the aorta or coronary arteries. That's the time we need to check if there is significant CAD or little plaque, and be very, very, very strong and aggressive about risk factor modification, including statins, maybe aspirin, and whatever it takes to get the reverse the plaque and soft plaque and prevent further heart plaque, and cardiovascular endpoints like stroke, peripheral vascular disease, and heart failure. So survivorship is very, very important on patients who have radiation therapy previously or anthracyclines, and in general as cancer patients as well. So in a picture form, they can cause arrhythmias, heart attacks, or heart failures, or blood clots, or hypertension. These are the common risk factors associated with most of the oncology treatment, including radiation and certain drugs.
So that was quite an extensive list of medications and different cancer types. So it's really the risk for cardiovascular disease, or the importance of cardio-oncology follow-up, touches every single cancer patient, especially as they become survivors and live longer, and the risk of cardiovascular disease goes up in the general population. So this is a very broad, encompassing topic that it affects many people. How do they develop these cardio-oncology programs, and what does that look like?
So it's a multidisciplinary teamwork. Our administrators in Northside system we are so blessed, very, very blessed to have such a great supporting administrators and oncology team working as in a close collaboration. So when I wanted to discuss about cardio-oncology program, I learned that our Northside system treats 15,000 new patients every year. It's only second to MD Anderson. We are second largest program in the entire United States of America to take care of cancer patients. And with high accolades and bone marrow transplant team, and the highest number of survivors, and such a great program with more than 50 cancer centers. So it will be it's a very highly collaborative system. Cardio-oncology program is with oncologists like you and several others, cardio-oncologists like myself and few others, and pharmacists and nurse practitioners, administrators, cardiovascular imaging technologists, and several others, OBGYN, Dr. Kanjuria, and so many. It's a collaborative teamwork to get the system in place and work together to increase the outcome. So this is how the oncologists and cardiologists, we kind of do it like a dyad model and getting together to form this cardio-oncology. And I recently realized that I should add one more arm to get the administrators in, and without their support, we can't reach everyone. So their help is indeed really big help for us, and support staff like Katie and several others, getting nurse educators and patient educators, and it's a good multidisciplinary teamwork which make all of us steer towards our success, towards our oncology survivors and oncology patients. So we form a multidisciplinary team to provide consistent, continuous, coordinated, and cost-effective care and facilitate treatment. And we want to identify high-risk patients before treatment, and we want to support during treatment to recognize early cardiovascular complications, and we take the care to survivorship for high-risk patients, especially anthracyclines and radiotherapy patients. So we have a dedicated navigator in our system. Now we were fortunate to have Cindy Wilson as our navigator, and she is available. She's highly passionate, extremely, very with cardiology and oncology background. So she is. We are blessed to have her here to take care of our, to initiate the navigation to begin with, and she can be contacted at that number and at that website. And she is one of a kind, and I was very happy to work with her. And so the ASCO guidelines also have the cancer guidelines and the American Heart Association ASC guidelines. We have so many systems: European Society guidelines, Canadian Society guidelines, Indian Society guidelines. There are guidelines from every country and every place, and in reference to our how to take care of these patients, how to identify these high-risk patients. And as you know, Cheryl, you, myself, and many others involved had formed a task force here at Northside, and we worked together to build the risk factor identification models, tools for our cancer patients who are at high risk, for easy identification, early detection, and such models like this are in place with the cardio-oncology task force from our task force now. As soon as either they identify several risk factors, and our cancer doctors are trying to plan for a treatment which may include these drugs, we kind of have a visual clues, go ahead, treat, and then follow cardiac associated diagnosis, or if they see very high risk features, to go ahead, send the patient early on to us, so that we collaborate and work together, either by telehealth or by trying to see them as a first visit coming into the office, and later on maybe by telehealth. That way our cancer patients don't have to travel too many places too many times. I've been seeing, as you know, your Jamaican patients through telehealth, and we all cardio-oncologists are situated in various locations and are available just a phone call away. And we have advanced technology, including strain imaging by echo for early detection of subclinical heart dysfunction, and immediately try to optimize their therapy with cardiovascular drugs or cardioprotective therapy, and also take the help of navigators and support staff in educating non-pharmacological intervention as well.
Okay, that was very exciting. We do have a little bit more time. Could you explain what you mean by strain echocardiograms?
Yeah, strain imaging is, I'm so happy and thrilled that our Northside system now has strain imaging in most of our locations. The Northside system acquired the latest in line of echo cardiology, echo machines with strain package in there. What it does is, just like when we are pregnant, or, we get the ultrasound, just the same way, the ultrasound sends the sound waves to the heart. If the heart muscle is this way, so the ultrasound kind of comes and hits each and every heart muscle cell. When it kind of hits, speckles are generated by the interaction of the ultrasound wave and the myocardium. So when the sound wave comes and hits the heart muscle, it creates speckles, 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 speckles. So we have so many speckles created because of the interaction of the sound wave. And when the cancer drugs and, the cardiotoxicity, the heart looks like one big ball of muscle, but there are several ways the muscle fibers are oriented. Some are oriented longitudinally, top to bottom. Some are oriented like this way, so, from radially, and some muscle cells are around like a ring. So when cancer therapy or drug therapy, it usually hits the longitudinal muscle fibers first, and then the radial and circumferential fibers get affected. So what we do is, with the speckle, we have a speckle here, speckle here, speckle here. The speckle moves from here to there and comes back. So we are tracking each and every heart muscle cell and measuring how this, like this. So when we send the sound waves, so many speckles are generated, and each and every speckle, the heart muscle contract, relax, and we are tracking them and then generating with the algorithm, and we get this data. By this data, this is called strain imaging. So we want to see all red, all heart muscles coming, all each and every wall coming together and relaxing. So what happens is this number should be around -18 or more. And for example, the longitudinal fibers, like these fibers, go down first. We see the speckles, that area of the speckles, the red becomes yellow and blue. When they are going yellow and blue, when we get so we are not waiting for the entire heart muscle to go down and then the heart function go down, and then we know, oh yeah, heart function dropped from 55% to 45%. It's too late, because if we do the speckle pattern before the longitudinal fibers drop, and then the whole heart function drops. So we can catch subclinically if the strain is dropping from 17 to 15, but heart function is still 55% normal. So we can predict ahead 2 to 3 months ahead of time that, yeah, the storm is coming. Then we can, get our medications optimized, more aggressive in preventive therapy. And maybe extremely, we don't want to do that, but at times I had situations since 2014. Dr. Lahiri once had a patient, heart function dropped from 56% to 43%, and we just had to give a break for the trastuzumab, Herceptin, and HP treatment, and waited for 4 weeks. And then I repeated the echo with some modification of etanolol to CoReg and things like that. And in 4 weeks, the heart function is back to 54% and then 56%, and then he restarted. So we just have to give a little bit break and let the heart catch up with that stress and heal itself, and then go back to the, very rarely we do that. Most of the time, if we are very aggressive with risk factors and heart healthy diet and anti-inflammatory diet with berries, and I spend half of my time also counseling about eating right and cutting down fatty food, and which can be inflammatory, and use less processing and more berries, and walking and such strategies all will help to give increased reserve and strain. This strain is a blessing, even though the data is coming up more and more recently, but there's lots of published data, and now how this strain helps us in various, not only cancer, but valvular heart disease, ischemic heart disease, and a special condition called amyloidosis. So that's about strain. So it's very exciting how the strain technology is evolving and very helpful, and we can take use of that advanced technology.
Oh boy, that is really complicated technology, but it is fortunate to have it, because obviously it's kind of like prevention. You find something before it's a problem or at its very earliest stage, so you can intervene and have less severe complications. So that's fascinating. Now, we've had a few questions come in.
Mm-hmm.
And so I'm going to summarize, and a lot of questions have been upon topics where individuals are on medications for their cancer treatments possibly, and they have seen some changes in their metabolic changes. So their cholesterol has gone up, maybe their blood pressure is a little bit higher, and they're wondering if that's just going to get back to normal when their treatment's done. Now, as their medical oncologist, I would tell them it's no time like the present to get on things and get it fixed, because since heart disease goes up with age, it may not all reverse easily when the treatment is over, and we don't want any damage done to the heart. Is that the right thing to tell the patients, or can we tell them that they can have they're already dealing with cancer, can they have a few months off?
No. Yeah, I think you said it right. I think, the reserve goes down. We don't want to let the reserve goes down. So what I would suggest is they should go hand in hand. As soon as, for example, we are talking about hormonal therapy. So if the patient has, for example, diagnosed with prostate cancer, and they need the androgen, deprivation therapy, they get anti-androgen medications. So then even though the LDL or cholesterol, what you may call as, is less than 90 or less than 100, in about 6 weeks to 3 months, if we recheck, the LDL may be 150. HDL may go down, or triglycerides especially may steeply rise. And because of the androgen, hormonal deprivation, the metabolism goes down. So as soon as the metabolism, then abdominal obesity, the fat gets deposited in the wrong places. Abdominal obesity, and then muscle mass goes down, and triglycerides go up, and the damage is done. And we saw how longitudinal fibers, these get deprived, with the plaque and all, low blood circulation, the subclinical LV dysfunction already starts. And then once it forms, small heart attacks and arrhythmia risks and heart failure risks and peripheral vascular disease risk. So I think we should, as we are working right now and planning our task force cardio-oncology services, we should be going hand in hand. And as the cancer is survived, we should take it away, continue the risk factor modification with pharmacological and non-pharmacological intervention. They should just go hand in hand.
Okay. Another question has come in. There are so many different testing in cardiology. So you have your EKG tracing, your echocardiogram, various forms of stress test and nuclear medicine studies. And the question is it better to have one particular test or another? Do they complement one another? Should you have a Lexi scan, a strain echo, a stress test, a cardiac MRI?
Yes.
Is there a best test?
We are blessed to have so many options in our hand, but I think I use it patient specific. The echo, it's hard to see the images, lean ribs are too close, or obese patient, or sometimes the breast, for breast cancer patients, they have augmentation, so the tissue won't let the sound wave go in. At the same time, we kind of use individually, we assess the patient individually, but for HP treatment like Herceptin, trastuzumab, the recommendations are to go with echo with strain imaging every 3 months. And if in case survivorship, for example, if the patient had radiation, I usually start screening for any blockages to the heart artery by a heart scan or a coronary calcium score 5 years from their radiation, even though they don't have any chest pain or any cardiac angina or chest pain or short of breath, but screening starting 5 years from their left-sided radiation, and looking for valvular heart disease, especially aortic valve regurgitation for left-sided radiation. And if they have head and neck, maybe in 5 years, check a carotid. So I tend to apply individually based on the patient's body habitus. And especially for women, I try to limit radiation as much as possible. Try to go for stress echo, which is 0 radiation, or coronary calcium score for ischemic evaluation with this extremely limited radiation, as we're going to high altitude and coming down kind of radiation. And expense is also very less, less than $100. So it all depends on, individual. So I try to kind of use all, whichever makes the best cost-effective and highly high information, high yield testing with very, very little risk of radiation and other associated factors into consideration.
So you really personalize things.
Personalized,
their health. Great. So, at the very beginning, you really showed where heart disease was #1, followed closely by cancer for men and women. Now, women typically don't always have the classical signs and symptoms of heart disease. Is there anything special that women should be looking for or thinking about when it comes to their heart?
Yes, women, 50% of women don't come like Hollywood, men, most of the in Hollywood picture of, oh, yep, I'm having chest pain. Women tend to be, tired, more fatigued, no energy. Then they used to do so much work, and they have to rest in between, or short of breath with exertion, or or sometimes they get jaw pain rather than chest pain, or sometimes they may feel like a indigestion kind of. A few years ago, we used to take call ourselves. Now our mid-levels help taking phone calls from patients in the night. But I got a call saying, one of my patients saying, I'm having a panic attack and I'm having extreme short of breath and panic attack, and where are you? And she said, it so happened my patient, I'm on call that day. I was on call that day, and she called, well, I'm sitting in the bathtub and trying to relax so that my anxiety spell comes down. I said, well, in the bathtub, come on, let's call 911, get out of there. And then she came in, she was having a massive heart attack with ST elevations. So sometimes if it is just, no explanation for, some discomfort or short of breath, or, sometimes patients may get dizzy because they were too much on their plate, they didn't eat, or too much dehydration or something. But if it is persistent and coming on and on again, and they can't explain why, I mean, it's always best to be checked out. They may have atypical features of angina, like anginal equivalent symptoms we call, like shortness of breath with exertion, easy tiredness, fatigability, no energy, especially altitude. If they go up the stairs, they get short of breath. There could be diastolic dysfunction. Women tend to have small hearts compared to men counterparts, and they have stiff hearts compared to, because data supports that women do less exercise for steps to steps. We take less steps than men, and women are more obese than men. If we look at 50 years, if you take how many men are obese versus women tend to, the menopause hits, for God's sake, triglycerides go up, HDL go down, activity go down, abdominal obesity comes in, depression, anxiety, so many factors play a role.
And as you mentioned earlier in the talk, there are a lot of medications that can have cardiovascular effects. So it is not just the anthracyclines or the HER2 agents. There's several chemotherapy drugs as well as the hormonal medications.
Right.
Are there any others? We've had several questions about several different drugs on that list. I didn't know if you wanted to show some of that list or explain.
Yeah, absolutely. Anthracyclines, doxorubicin, daunorubicin, that group of drugs are age old, since 1970s, we know that. And we used to monitor, when I was a fellow and resident medical school, we used to have patients with anthracycline. We used to do MAGA scans to check for heart function, but that's lots of radiation and we get only information about heart function. Now we have advanced technology with echo, which does have zero radiation and less expensive, and get more information, including valvular heart disease, pericardium, heart function. So we're not using that anymore. Later on in 1990s, we have this Herceptin and trastuzumab and pertuzumab, what we call as tyrosine kinase inhibitors, which are used in, mainly breast cancer, and also with Avastin. I had recently a patient, several patients, but one of the patients had significant elevation in blood pressure. As soon as, usually these VEGF inhibitors group of drugs have about 3 to 4 weeks from their first cycle. That's when the 20 to 80% increase in chance of blood pressure, steep rise, and extremely difficult to control because they're mediated through nitrous oxide, various explanations, capillary resistance. So the lower number, diastolic blood pressure, is a huge problem for them. Very tough to treat. Sunatinib, again, these drugs for GU, urological cancers, kidney, and such that, and they have also hypertension, and then with hypertension comes the risk of stroke and heart failure. And we have these multiple myeloma related drugs. They are also associated with arrhythmias, heart failures, and exploding now. As you see that almost yesterday I saw 3 patients for cardio-oncology, out of which 2 are immune checkpoint inhibitors. So with Pembro and things like that, so they have myocarditis, arrhythmias, heart blocks. That can be. They're rare. I mean, this cardio-oncology is not to scare patients. As soon as I walk into the room, first thing I say is, you're not here for you to be scared. You're here to be proactive. You want 2 to 20%, you want to be less than 2%. You will not want to be more than 20%. You want to reduce the risk if you have to, from 28% risk to, for example, if you see the cyclophosphamide, 7 to 28%. Why is that? Because people who are smokers, hypertensive, hemoglobin A1C off the roof, they don't want to move, not eat right, the risk is 28. If you do take care of all that, the risk is less to 7. So our goal is to reduce the risk, and even if 7% risk, to identify early. For example, if a patient comes in with Pembro yesterday, I was telling her, she was so anxious. I said, you have your risk, you have zero risk. You don't have, except your age around 50, 60. There is no hypertension, diabetes, high cholesterol, nothing. All you have to is watch out for myocarditis. That is, if you get short of breath, if you get dizzy, if you have, you need to just call us right away. We have ways to detect early and intervene in a fast manner. So there is no fulminant risk with that therapy. So all these drugs, especially now checkpoint inhibitors, correct me if I'm wrong, almost 40% of cancers, they're looking into immune checkpoint inhibitors, right, for therapeutic options.
Correct. Correct. So yes, so lots of medicines can have lots of different effects on the heart and on risk factors for future heart disease, and we need to pay attention to everything.
Right.
If we do that, it sounds like we can slow down and even potentially reverse those risks. Is that correct?
Yes,
Okay.
reverse the risk.
A lot of hope. Well, we're running out of time for questions today, but there is one more question about the referrals to cardio-oncology. Is this one that needs to only come from an oncologist, or can their medical doctor or even the patient self-refer if there's interest?
Yeah, absolutely. I mean, the oncologist, anyone can refer. We have the reverse act. I know we're running out of time. This one particular slide is absolutely amazing. This study had shown that if we identify the risk within 1 to 2 months, 64% had back to normal heart function, whereas if they identify 4 months later, or if they identify after 6 months, they can prevent future, but they cannot reverse. So this slide is what you summarized just now. So sooner we detect, the better. So that's why if the patients have shortness of breath, heart failure symptoms, they can call their oncologist, they can call their medical doctor, or pick up the phone and call our Cindy, who is our navigator, and she is so good. I mean, we had somewhere her line. I guess I'm sure Katie can post in the website. They can call her directly at this number, or they can call. This will be on the website, I'm sure, and my number is on the last slide. They can call our office and schedule the appointment, or they can get in touch with their oncologist, and they can provide that anyone can make an appointment. Well, and our goal is to get into cardio-oncology service line within 48 hours. We are trying to I reserve my 11 o'clock and 2 o'clock up until 24 hours before. For cardio-oncology patients, if it's not filled, then 24 hours before they fill that slot. Many cardio-oncologists who are very passionate about this upcoming field, they have their own accommodations to get these patients as quickly as possible.
Okay, well, thank you, Dr. Medepalli. That was a lot of really good information that I think will be impactful for all of our cancer patients and cancer survivors in looking for the best outcomes. I'm now going to turn it back over to Katie Amsbury with the cancer support community. And thank you all for attending this February meeting today.
Yes, thank you both today for such great information. We're getting a lot of positive feedback in the chat box about how helpful all of this was. So thank you everybody for joining us. Thank you for such great questions. And right before we wrap up, I do want to throw it back to you both, Dr. Medepalli and Dr. Jones, for any kind of final thoughts. Dr. Jones, I'll throw it out to you first.
Oh, thank you. Well, I think that the importance of this information, your number 1 and number 2 diagnoses that need the most attention is preventative care for early diagnosis of cancer, and preventative care and proactive care for your cardiovascular health. And this marriage of this new cardio-oncology program is an exciting thing for the future. So I hope that we get the word out to everybody about these opportunities.
Right. Yeah, I can't say more. I mean, it was my absolute honor and privilege to share a stage with Cheryl. I encourage all our listeners to be proactive and spread the word to their friends and families and dear and loved ones to take care of their cardiovascular health while getting their oncology treatment.
Thank you both. And if anybody knows of someone who wasn't able to attend today's live program, we will have the recording available on our website, and that's cscatlanta.org. So you can share the recording of today's program with them. Thank you both again. If someone would like to get connected more with Dr. Jones, you can visit Georgia Cancer Specialist website. That's gacancer.com. And for more information on the cardio-oncology program with Northside Hospital, you can contact that phone number 404-263-2753 or email cardio-oncologyprogram@northside.com. Thank you everybody again for joining us. Have a great afternoon. We hope to see you soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.